just want to welcome everyone here today to the Patrick David Roberts Health and Wellness Center. We continue our conference 2020 with the Bahamas Podiatric Medical Association. Today we are very pleased to have Dr. Delton Farquharson with us, who is a general and vascular surgeon and who has really dedicated a huge part of his life and energy to saving the diabetic foot, to limb salvage. And part of this, last year we had a great presentation by one of the professors at the University of Chicago who talked about the VIPs. When you're saving these limbs, it's vascular, infection, and then pressure on the foot. If we can control those three, we should be able to save your limb, and that will change your life. So today we want you to welcome Dr. Farquharson. He's here to talk about the flow to the toe, and it is really about making sure the tree got enough water so it can continue to grow. Without further ado, Dr. Farquharson.
Thank you. I'd like to say thank you to Dr. Johnson for that kind introduction. And I also would like to say thank you to the Bahamas Podiatric Medical Association for inviting me to participate in their annual conference. Today we're going to talk about flow to the toe. And flow to the toe is a concept that came about because of a collaborative effort between podiatrists and vascular surgeons and other members of the healthcare team to save limbs. And we know that if we can keep blood flowing all the way down to the toe, we can save a lot of limbs. Next slide, please. The other thing today is actually World Diabetes Day. And I just want to take a moment here to focus on the theme of World Diabetes Day. Next slide. And the theme this year is diabetes, nurses make the difference. And we in this COVID era now, we have and all the comorbidities that go along with it. We have nurses who go beyond the call of duty. And I just want to say a special thank you to nurses locally, regionally, and internationally who contribute to diabetic care and make life better for diabetes. Next slide. So when we look at our little country, physicians make up about 25 out of 10,000 population. But the nurses actually almost double that. If you put the registered nurse and the trained nurses together, they practically double the physicians. So nurses can go a long way to having an impact, particularly on diabetic care in our little society. I have no financial disclosures. And just talk, I'm going to start with a typical case. And this is a typical case. This is a case that I've been working on in the last few months. And I'm just going to show you how this progressed and how we achieve flow to the toe. Okay? So 81-year-old male was referred for poor healing after management of a right ingrown toenail. He presented a year earlier with numbness and tingling in both lower extremities. And he was investigated. He found that he had diabetes. But diabetes is one of these sinister diseases. You can have it for 10, 15 years and have no idea until the symptoms show up. And so this patient showed up with numbness and tingling, and all of a sudden he had diabetes. And some other complications from the diabetes, if you look at his age. In April of this year, he noted an ulcer beneath his right great toenail. And so he visited his physician, and he was seen and assessed, and he had removal of that right toenail so to expose the ulcer. Lo and behold, the toe wouldn't heal. Okay. And he experienced worsening pain. Next slide. As a part of his comorbidities, he had hypertension. He's had that for a long time. He's had diabetes, and all of a sudden he had diabetic peripheral neuropathy. He also had prostate cancer, for which he was still receiving some treatment. And so when he was referred to me, he had breast pain by the time he was referred, and this right great toe was discolored. And the physician was treating him for an infection at that time. When he examined him, you could see basically, he was fine. Only abnormality from my perspective, other than the physical findings, he had no pulses at all. Wow. No pulses that you could feel in his. Next slide. And this is a picture of what his toe looked like when I saw him. And you can see that, the toenail was removed and it's a little dark, it's colored and cyanotic. Next slide. This is the progression several months later. You can see the dried and look a little bit better. Next slide. And then, you see more crusting, more callus. This was evidence that there was no form of healing. The body was trying to do what it needed to do to heal this toe, but then nothing was actually happening. Next. And then progress to gangrene. All right. And you can see that on this slide, this toe is totally gangrene, it's mummified, it's dry, and there's no signs of infection, but it's totally dry. And unfortunately, most people present with a problem like this. Either the toe is gangrene, or the foot is gangrene, or you have an ulcer that's not healing, or something. They wait until there's some catastrophic event to show up. Next slide. So, being a vascular surgeon, the first thing I wanted to do was look at his vasculature. I wanted to see what was happening. And you can see, he had fairly good inflow disease, but when you look at his foot, there was practically no flow to his toe. Literally no flow to his toe. I usually tell people, and I usually equate this analogy to what the Bible says. The Bible says, for sins to be remitted, you have to have shedding of blood. For foot to heal, you need to have blood flow. You have to have blood flow. There's absolutely nothing going to happen to this patient with no flow to the toe. Okay? So it's important for us to send that message on everywhere, every diabetic. Vascular flow is important. Next slide, please. And so we had to settle on a plan, and we tried to get this patient prepared for what is to come. He was going to he had threatened that he was going to lose both of his feet, the right foot first, eventually the left, if nothing is done. Okay? And our treatment plan, because of his comorbidities, his frailty score was average, was okay. And, even though he was 81, he wasn't as frail as most people expect an 81-year-old to be. And he was in pain of having surgery at that time, because open surgery for this kind of procedure is long, it's tedious, and you have to be fit, cardiovascularly fit, to undergo a procedure that may take anywhere from 4 hours to 8 or 9 hours. Okay? He wasn't prepared to undergo it at that time. So what we did is we look at all the options that we have for limb salvage. And in his case, he was able to afford stem cell, so we tried stem cell. And so we got an emergency use authorization for the use of mesenchymal stem cells. Next slide. Oh, sorry, just go back a minute. And there's a strict protocol that we have to follow when we're using stem cells. And you can see all these markings on his legs. So we have a strict protocol that we follow. Every 3 centimeters, you get an injection of a half a cc of stem cell along the vascular distribution on the limb. We start from the lower thigh and we go all the way down to the ankle. Okay, good. Next slide. And we thought that we had some success, because what happened is we do some studies, and there you see that he had audible Doppler flow, and after several weeks and all that. And so eventually what I did was I said, well, this toe had progressed from having been dry to having wet, because now he got the blood flow. Okay? And so we went ahead and we did an amputation of his great toe. And that is what it looked like a week after surgery. Okay? So we thought, you can see the tissues are pink, and we thought that we'll pet this along, and whatever adjuvant therapy we need to give him, we will do. Unfortunately, the patient decided that, you know what, like everybody else, salt water is the holy grail of healing. So he decided that he's going to, this foot need to go, he needs the blessing of the soil.
On the beach.
Go on the beach and do all sorts of things. And lo and behold, all our work went down the drain. Next slide. So I'm going to just pause right there and tell you how important it is for flow, for blood flow to get to the toe. Next slide. Every year, every 30 seconds, we amputate somebody. Around the world, 1 million amputations will happen at any point in time before this day is out. So we do 1 million amputations every year. So every 30 seconds, somebody is losing a limb somewhere in the world. Okay? So the treatment and care of people with diabetic foot problems have exceeded most health budgets. We can't afford to take care of these people. Remember what I said earlier, most people don't find out that they are diabetic until about 10 or 15 years after they've been diabetic. And so by the time they show up, they have many of the complications of diabetes. And one of the major complications is macrovascular disease. We'll talk about that a little bit. So taking care of diabetics exceeds, if the government of the Bahamas have to take care of just diabetics, it'll be more than whatever they're spending on healthcare right now, the $200-300 million that they're spending on healthcare. So just imagine that. Next slide. So foot infections in patients with diabetes is a significant morbidity and cause most people to die. It is the #1 reason for amputations in the United States and even worldwide, in the UK, in France, in Spain, everywhere you go, in Portugal. It is the #1 cause of amputation. And the continued rise in the incidence of diabetes in developed and developing countries, all of us are getting rich, we're getting midlife spread, getting weight, and increasing body weight. And because we are living longer, all of this will cause this problem to explode by the year 2040. Okay? Diabetic foot infections, however, need special attention. It really needs special attention. Next slide. And diabetes and diabetic foot should be considered an epidemic because every day, there's not a day pass that I don't see 3 or 4 people with a diabetic foot that is infected, that is gangrene or something. Every single day. Okay? And we anticipate that because of this, we're going to have more infections, more ulcerations, more amputations, because we have an aging population. That patient was 81. Most patients, remember, most diabetes isn't diagnosed for 10 or 15 years after you've had it. So most patients are going to be in their middle age or older when they actually find out. We have an increasingly obese population. The last health and wellness study we did showed that over 70% of the Bahamian population is overweight. Okay? We have no national plan. Johnson, I always hear him because he was in cabinet. We have no national plan for these problems. No national plan. Okay? And I can't say that there's one in the making. I cannot say that. Okay? We have to promote education. We have to get people aware of this problem. Because we're going to, as many limbs as we lose, that's as many lives that we will lose. Next slide. So the risk factors for these people are age. We know that as you get older, the more likely you are you're going to have some problem with your leg. If you smoke, you're 2 to 6 times more likely to develop a problem with your legs. And if you add that to diabetes, you're going to have a problem. If you have diabetes itself is a risk factor, okay, remember for every 1% increase in your A1C, everyone know what A1C is, that's what we use to measure how well controlled your diabetes is. So every 1%, there's a 27% increased risk of developing peripheral arterial disease. Okay? So just remember, if the normal is 5 or 6, and you have yours is 7, just remember you're 26% more if it's 8, you are 52% more likely to develop a problem. So just think about it like that. Next slide, please. Other risk factors that go into this is people who have high cholesterol, dyslipidemia, abnormal cholesterol, patients who have hypertension. Next slide. Patients who have hyperhomocysteine, not very common in our population, right? Patients who are obese and our race. The fact that we are dark skinned and we are ethnic puts us at risk for developing these problems. Now I put alcohol in there. Now, alcohol has probably been the only thing that is shown to be protective. Now, alcohol in excess is not good, but certainly it has been protective more for men and not so much for women. Next slide. We have some inflammatory markers like so what we're finding out now is patients who have chronic infections like periodontal disease or chronic arthritis or septic arthritis. These people are at an increased risk for developing peripheral arterial disease. And last on this list is chronic kidney disease. If you have diabetes and hypertension eventually and is not controlled, eventually you will get kidney disease. Kidney disease adds another 38% risk of developing a diabetic foot problem. Next slide. So when we are presented with a diabetic foot, we have two goals in mind. We look at the limb and we look at the life. We look at the limb and we look at the life. For the limb, we want you to be able to walk and have a good quality of life. So we want to prevent anything from getting worse. We want to save you from getting an amputation, right? We want to save your limb. And then we look at your life, because what we know that patients who have diabetes and all these complications, they end up dying. What do they die from? They die from heart disease and they die from stroke, right? Heart disease and stroke. And most patients with diabetes don't even know when they're going to have an MI, okay? And so that is our goal. Our goal is to save your limb and in the process save your life. Next slide. And so in getting flow to the toe, there are several mechanisms, there are several modalities that we can do. I'm a surgeon, so surgery is what I do. We can actually operate it. Like I say, the operations is very complex, and we can actually get blood flow to the foot. Okay? So surgery is something that we can do. And remember the goal. The goal is to get flow to the toe to save your limb and your life. Next slide. And if you look at all the research studies, you look at all of them combined, just this slide just show that you have evidence that we can operate on patients and have some level of success. Next. We can do bypass above the knee, we can do it below the knee, we can use different type of materials, you can use your own material. That's all the same. There's enough evidence in the literature that we should be able to do this successfully. However, surgery has a lot of complications, a lot of it. Again, remember I say surgeries are long, and so because you're under anesthesia for so long, then you have other risks developing because of the long surgery. And so these are things that have to be taken into consideration. Next slide. Or you can go to the next slide. Next slide. Okay. And about 20 years ago, we developed, not everyone is a fit candidate for anesthesia, or not everybody is a fit candidate to go for long surgery. And so we had to find a new way to get flow to the toe. And so we came up with this endovascular type of surgery or minimally invasive surgery that you'll hear about. And so now we're able to reach the toe through a needle and with a bunch of wires and some needles. We can actually get flow to the toe. And there are different mechanisms through which we can do that. Angioplasty is probably the more commonly things that you've heard, because it's more commonly done for people who have heart attacks, and they do angioplasties. They can open up blood vessels in the heart. They can open up vessels for patients who have stroke. We can also open up blood vessels in the legs, okay, using some of the same technology. And there are different type of things. For patients who have dense disease or calcified plaques, we have what we call atherectomies. And atherectomies has not enjoyed a whole lot of music in the past, but because of technology and redevelopment, and they are coming back and they are actually adding. So now we can actually open up all these calcified vessels again because of new technology. Cryoplasty is a technique where you freeze plaques and then break it and then you have them open up. And then we have endoluminal grafts, endoluminal stents, and we actually have lasers that we can actually open up blood vessels all the way to the toe. So we have many ways of achieving flow to the toe. Next slide.
Okay.
The technological breakthroughs, we believe, will lead us to the pot of gold. Next slide. And again, we talk about all these different type of things that help us now: lasers, catheters, rotobladers. So we can do things. We can open up plaques. We can open up all these blood vessels again, and we can actually achieve some of the things that we can. Next slide. Again, new technology. We have so many different things now that we can actually use. We are developing wires, catheters, and all different types of technologies that allows us to achieve our goals. Yes. Next slide. Some fail. Not everything works. And not everything works in everybody's hands. So some things work with some people and some things don't work with people. And so you don't always end up with a pot of gold. And I just want people to be aware of that. Next slide. Okay. There's medical management. Unfortunately, medical management, next slide, has not proven to restore flow to the flow, but we use it in an adjuvant manner. What I mean by that, if we open up your blood vessel, then we need to give you medications to keep it open, and that's where it comes in because, and that's where medical management comes. And there's a whole lot of things that people have tried, a whole lot of mix. Next slide, and we know that none of it works, but we know what works next. So what really works? Next slide. So when it comes to medicine, people don't like this. People don't like this. I had a conversation with a patient this morning, and I told her that she have to go walking 30 minutes a day. She said, "Doc, I really gotta do that?" Yes. These are the things that work. Lifestyle modifications. If you start smoking, it's gonna work. If you control your diabetes and hypertension, that will work. If you get supervised exercise, 30 minutes at least, at a minimum of 3 times a week, that will work. If you lose weight and get back to your ideal size, that will work. If you control your cholesterol, that will work. And last but not least, we need to get on a healthy diet. Not beans and rice and macaroni and potato salad and da. All right? Healthy diet. So we can keep our cholesterol low, we can keep our blood pressure controlled, and we can keep our diabetes under control. Next slide. We know those work. There is the evidence that it works. Next slide. More evidence. Antiplatelet therapy. So we put most patients on aspirin. People say, "Why do you get aspirin?" We put you on aspirin because we don't want those platelets, those smaller blood vessels inside the blood to stick together and cause you to have a clot. Evidence that it works. They have some medications that are a little bit better than aspirin. They cost 3, 4, 5, 300 times more than aspirin, but they work. And we use aspirin as a poor man's way to help people. Next. A unique drug. This drug is a unique drug. It's silostazole. Probably the only indication is for patients with peripheral arterial disease. Why? Because, next slide, it works on the platelets, so it stops them from sticking together. It works on the muscles inside of the blood vessels. It causes them to vasodilate, and it works on lipoprotein lipase, so it decreases your triglyceride and increases your HDL levels. And it does this through a lot of mechanisms within at the cellular level. And this is the one drug that is shown to be effective in helping us maintaining flow to the toe once it's achieved. Next slide. So back to our clinical case. Anyone wants to know what happened to the patient?
Yes.
Yes, please.
So the patient developed red gangrene, so we end up having to do the amputation of the toe. Remember that? Okay. So we went ahead and we planned a next phase. And after consultation, we said, you know what? I'll try some endovascular technique. So we went ahead and we got him into the cath lab, and we accessed him in his groin. We put a needle in, and we put a wire in, and we put a catheter in. And then we went to work. We probably use about 6 or 8 different wires trying to open up all those blood vessels, all right? And so those are just the vessels that had more of the occlusion or the blockages, and we open all of them up, all right? And we got flow. In fact, it was so good that where we did the amputation, the wire actually came out of the site we did the amputation. And so we know we had achieved flow all the way down to that point, which was excellent. Next slide. And then this was the wound. This is how the wound looked the week afterwards. Next slide. All right, so this is how it looked a month afterwards. Next. And this is how it looks 6 weeks afterwards. So his wound is actually healing. All he needs now is good wound care. Good wound care, and this will heal. All right. Now, what we achieved, we only opened up one blood vessel. And that took about 2 or 3 hours. So we're gonna bring him back and we're gonna open up a second blood vessel. There are 3 blood vessels in the legs that need to be, and at least one need to be open for blood to flow. For the sins to be remitted. Just one have to be open. But we're gonna give him 2, we're gonna open up 2 so that he will be able to enjoy a better quality of life in the future. Next slide. So in conclusion, I just want to say 1, diabetes is very prevalent in our society. 2, diabetes causes accelerated macrovascular disease. It causes a lot of damages to the blood vessel. Arterial disease and diabetic complications lead to critical limb ischemia. And we say critical limb ischemia because limb loss is imminent. Okay? If you have no pulses, if you have an ulcer that does not heal, if you have a gangrene on your toe, or your resting ankle breaking index is less than 0.4, if you do absolutely nothing, you will lose your limb. And when you lose a limb, you reduce your life expectancy anywhere between 40 to 60%. Okay? So what it means is about 4 to 6 people wouldn't get to see 5 years. That's what it means. And so, being able to achieve flow to a toe with a variety of techniques, whether it's open surgery, whether it's endovascular, or even whether it's stem cell. And we do this so we can prevent amputation, we can save limbs, and eventually save lives. Next slide. I love this slide. Dr. Johnson, you gotta have a copy of this slide. The flow to the toe concept happened between these 2 individuals, the podiatrist and the vascular surgeon. Because we know that if we can achieve flow to the toe, these people could fix your foot and you will be okay. And then we have a lot of other people to help us. We have a lot of other people to help us take care of your limb. Dr. Johnson, I say thank you for inviting me here. And thank you to the audience for listening. Thank you.
How old are you, Mrs. Smith? 62. And Mr. Smith has been a runner his whole life, Dr. Thompson. He runs, a distance runner. This joint now, you're diabetic, correct? Okay. So this joint now has kind of let him down. Okay. So in these, one of the things we do when we do these examinations, we look at the flexibility of the toes, whether you can relax your foot. I'm not going to do anything to you. So whether these can move or not, these all right. In this joint here, no motion whatsoever. That's that joint of the big toe. That does not move at all. When he's an active person, he's not an ill man. But he gets, every time he gets going, his foot break down, boof, this thing opens up, and he got months and months of fooling with his ulcer. So today we're going to solve this problem for him permanently. You see this quality of skin? All right? What's going on with this? So as you get distal circulation, this is changing. That's better. So we have a circulatory change. So you're going to check this dorsalis pedis, what's going on here. And if you cannot, I can feel it. We've done this, but this is for the purposes of demonstration today. I want us to make sure we can hear that. I can feel it. And his posterior tibial. Okay, the posterior tibial is easier, and this one is harder. Okay, with posterior tibial nice and bounding. Because in the years to come, we may not have the circulation we have now, but this joint cannot move, okay? And so this will break down on us. It will, in any matter, so it's happened before, it's gonna happen again. And today, we're gonna give this a little bit of motion, so this, feel that underneath there, how hard it is. See how close the bone is to the skin? And then this joint now, his IPJ joint, try to see if you can bend that back. Right, it's fusing in place. So now I'm going to do an osteotomy across that joint and slide it up just to take a little bit of pressure off this toe. And that's going to last him maybe 10, 15, 20 years of not breaking down. Alrighty, Brother Smith, I can lay you back a little bit. Little swab there for me. The nerves and blood vessels run together. They're concomitantes throughout the entire human body. And when we're working on this stuff, we're blocking the innervation. So only these two vessels and nerves I need to control. There are two on the top and two on the bottom. I'm now about to turn them off so I can work. That's it. And we can get in and out of these joints in a minimal way. This is minimally invasive surgery. Right across that. So I'm doing the H block here. Hey, Reg, well done, man. You can come and watch this one. Very good. And then underneath here, just put a little bit underneath. So you can see where where that bone was open before. That's the tip, that hole there. Came all the way down here. That's the middle of it. Just a piece that went to bone. All the way down there to there. All that was open to bone. So when that comes back again, my friend, this thing can be nothing to play with. And I want him to call me and say, Johnny, guess what? No. You ain't gonna guess what on me. Yeah, I think you can. Give me a picture. Good. Can you all see this? Okay. So see where my pin is? I'm in the joint. I'm in. We jamming. So once I got that marker, I'm not fiddling around. So I'm not gonna open the foot anymore. I know where that is. I'm going right in there, where you're gonna feel where that bump is that caused the ulcer. I'm gonna shave that down. The bone piece is gonna come out. Fix his toe where he can. You'll see motion in that toe now, and he's out of here. Put your foot back up. And I don't really touch these. Like, you could leave it in and just do. Some people use these as guide wires, but you don't. Another part, you see the ulcer too. So you're really going just distal to the ulcer. Okay? All right, sir. Bam, boom, beanie. We're out of there. On the top, there's no integrity to that skin for you to do a big procedure. You'll be fooling yourself to think you could do that. On the side, though, you got enough juice, enough flesh, enough soft tissue, a little bit of muscle. You could do a lot of stuff on the side, but try not to do it underneath. So take this fella, goes up here, boom, one there. Take one more. This is Mr. Smith. He's a 62-year-old diabetic. He is a runner, and he has severe hallux rigidus hair in his toe. Had a massive ulceration last year. A couple years ago, another problem. So this is an ulcer that maybe was, let's see, 7 centimeters at its pinnacle. Went all the way to bone. We healed it up now, right? It's closed. But I told him I can't take the chance, and he wants to still run. He's still fit. And so we're doing an osteotomy to the base of this MPJ, and where the ulcer was, there's a big piece of bone sticking out. So we shave that, let the bone paste come out, do the osteotomy, slide the bone up, okay? So before we start, I just clear all of this stuff, make sure there's nothing underneath it. Diabetic foot could fool you. It hides things, so before you begin, always Double check, make sure there's nothing underneath there. Make sure nothing on the side here, that is. So you get little pockets that can develop. And so I like to move all the dead skin. Make sure I'm going into fresh tissue. You don't have to draw blood, but you do want to make sure it's clear and clean. So you can see that's the old ulcer. And there's our big point of contact right in here. Okay, so we're going right underneath there. That osteotomy and maybe in good shape. Boom. Part 1. A little spray again, Felici. Special solution. Look it on that. Good. You know, Thompson, I like sprays. I don't like too much dabbing. And that's a good spot right here. So that's the point where we had our needle in. And we're going right back. And that was the origin of the ulcer. So this is, we triangulate these procedures where I'm wanting, this is the place I'm going to, but that's not safe to go in there. So what I'm doing, I'm going this way to get into that. Okay? We're going this way to get into that. And get ourselves a little motion in the ocean. Right here. Bam. That's my spot. And we use these tiny blades. Give me 64 again. These are called MIS blades. It's a beaver blade handle. Once again, in the old days, to do that, we'd have to open that toe about that much to flap that down, because I don't want to go underneath, but flap it down. And you can see from that diagram behind you, boy, you got a lot of work to do. Opening is easy. It's like opening a computer. Easy to open it, closing. and when you close it, guess what? You got to work. And that's where things go a little spooky for most people. So here we're going in the neurovascular bundle. One is on top, one is on the bottom. One is on top, one is on the bottom. So I'm going in between. And this is our origin lesion. We're triangulating this object, okay? Straight to bone, I'm in the joint now. Literally right in the joint. Go underneath here now. And that's the spot. Okay, you're in his joint. You feel anything, Mrs. Smith?
No.
Thank you, Lord. That's always good news. Now, because it's an old ulcer, we got a lot of scar tissue here. Anything I bump into will be my issue, because I'm the one who healed. I had to do the secondary wound closure. You had to pull all that tissue together. This is fine. Got an elevator, free elevator. Okay, so we're in the joint now. I want to go in. It's a curved instrument, so I go in and this curves around a little bit. Still just in one spot here, going around. And we're there, okay? Now he's a runner, boy, he got good bone. So when you do this kind of work, don't miss breakfast or nothing like that. Okay, can you hear that? That's the bone spur. We're gonna knock that off. And then we are gonna get this up and over. Get underneath here a little bit. Go under and out. Okay, get my burr ready, Felicia. Good. Magnifico. Boom. Rub it there while we set up my burr. Lady Di. Bam. This is an Osada oscillating bone drill. Goes really fast. This is what allows us to work inside the joint with expert precision. It's pretty fast, it's pretty cool. Japanese made precision tool. Okay, you can touch the handle, you can, just like the stuff we do in arthroscopic surgery and stuff we do for laparotomies, laparoscopies, whatever you want to work on. Okay, make sure the top is nice and sealed. Once that is sealed, we're good. And so first I want to get a little bit of that bone stuff out of there. Little bone stock to go, and then we're going, we're rolling. Bam. You good, sir? Bone. So no one likes to go, back into wounds. But to get these to heal, you have to, all right? You gotta go back in there. We're on bone, hear that? That's the bone. Boom, under the joint. Okay, right in the middle. See, it's coming right through. So when I'm done, so when I started, I could hardly move this instrument. See now, it can go back and forth inside the joint, okay? And I'm going to be mimicking the motion I want him to get back in his toe, so this doesn't break down constantly. First incision. For him, there are going to be 3. Second one is to clear everything off the bottom now. Second incision. Boom. In the joint. Now we're going underneath. So where I put the needle on the x-ray, you only got one hole. You ain't nowhere else, and you're inside the joint. Okay, you're not on the nerve, you're not on anything else. You hear that bone? I'm in the joint. I'm coming, I can put my finger now, and I can feel the vibration on the side. Okay, I have my thumb right above the burr. And now you're going to see the osteophyte is going to be breaking up, and the bone paste is now going to come out. Beauty. See the movement I got now in here? Nice, man. This is the part where I'm wishing one of my nephews goes and says, geez, man, I think I'd like to do this, None of them do it. They all go like, yeah, man, you look like you got a lot of work on your hands, uncle. Congratulations. Okay, so it's a lot of stuff in here. So I'm going to show you all how the bone paste. So I'm in the joint. So remember that hair that was so hard? Okay, it's going to be soft now. And I'm contouring this a little bit. I want to come around the back there. Thinking about him running now. I'm not just thinking about this wound not breaking down anymore. I'm thinking about him going for a run one day. So this is a great question for you, Dr. Thompson. In wound care now, people are doing all sorts of stuff. But we know when healing, there's a new thing that everyone's rushed towards. This pre-COVID, everyone was talking about it, and we know creates tremendous healing. What is that? in the world of wound care and healing now. People are talking about mesenchymal stem cells, right? So what is in the middle of bone?
Bone marrow.
Yeah. What are marrow cells?
They are the pluripotent cells you find in bone marrow.
Yeah.
So they're the cells that have the ability to be any kind of cell almost.
And so all this big news they're telling us about stem cells, is that news to us? No. So I'm going to show you all. This is the marrow from that osteophyte. That's bone paste. That's bone marrow. It's not blood. It's bone marrow. Okay? So I'm not going to take all of it out. Why? Because that's also going to help heal.
Healing process.
Help heal this process. Now, look at this toe. What couldn't bend? Hello? Jingling, jingling, jing, jingling, jing, 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 jing. You bending, man? Yeah. Listen, yeah. Don't go running tonight now. Don't get too excited. All right? But the toe could bend now because I took the osteophyte away. So osteophytes in joints like a pebble in a door. You see all this? It's a pebble, so the door go to swing and go. It jams because they got the pebble in the door. Now in a diabetic, no one in the world would go inside this man's foot with them old procedure we used to do. Be crazy enough to go open this foot. No, sir. But we did it. He's awake, and we got motion in the ocean. Good, no pain. So sweet, man. You could hardly see my incision. Okay. So I gotta go call out two things I want to do. I'm just thinking about him running. And I think I can get. No, you're moving your toe. You keep your toes. You don't have to move. Just let me move it. You don't move it. Just let me move it for you. He's still moving it. You're so happy you can move your toe now. Take your time, man. Take your time. Take your time. No rush. No me toques. So I'm going to do a little osteotomy to the top now. Different blade. Do a tiny wedge osteotomy to the top with a different blade. Just to give me another pack of gauze there, please, Felicia. Alright, so do a tiny osteotomy to the top. So these osteotomies now, when you're thinking about your final cuts for the patient, is like taking a little piece of pie. So picture a pie. So what I'm wanting to do now, his bone is in the right position, but I want it to bend more up. So I'm going to take a little wedge from the top of the bone. So when it heals and the wedge closes, it'll close. That'll bring the toe in a more upright position. Just take a little wedge. So we're going to take a wedge from the top, boom, and we're out of there in the same hole because we're in the same joint. Okay? Same hole, same joint. The juke joint. Thank God I could see the hole. Alrighty. I want to get right in the middle. Probably right here. Good. I'm going right through. Coming right out here. Nice and smooth. So this drill is a great innovation because the old drills used to burn bone. Because if you go too fast your bone, it'll burn and then it won't heal properly. So now I'm going to be able to go through, so I'm right through. Good. And now I'm coming up. And I'm coming to the top of the joint now to just take a little wedge out. And we're out of this foot, man. And this is done and Felicia does the picture. You'll see the actual cut. Okay, so I'm through. And there's also, in hospitalization of these kind of cases, the issue is the infection. So because I'm in a portal and I'm in the joint, I'm doing all this work, your chances of infection, not none, but your chances of infection are very slim. And patients appreciate that. For the diabetic, I think it's essential. Okay, you hear that click? When you hear that click, I am through. You don't have to move your foot, man. Relax your foot, don't move at all. Good. I want to see how much, okay, so now we see how much motion we got in it. Okay? See that? From where it couldn't move at all, and that's the range of motion. So when he does go to run now, at least we got that. See that? That's good. Let me suit you, Felicia, and then you can take your picture, so I don't lose too much. And that's, and he got such good bone stock. You got to be a little firm with that. You got some older people, you could take your toe and snap it. Boy, not on him. You snap your hand off. Any questions, maybe, sir? Anything you want to ask? None? Well, you're in good shape then, no problem. I'm with you. Good to go. So I do a little banjo stitch here. One there, and then one across the other way. Let's see. Did you enjoy the music?
Yeah.
Yeah. What you doing for the weekend? Hey, that's a good answer. You know, some of my parents say, boy, I plan on going to Miami. I'm like, oh boy. And they go. What his name, Mr. O'Brien. So O'Brien going to watch the Dolphins, man. Say the only reason he get mad, they lost. Say that, so he come back and say, boy, I so mad. I said, what happened? Is happened to your foot? He say, no, my team lost. That's where he was, in Miami. I'm like, oh, jeez. Yeah. Boy, you like Florida, eh? Jeez, man. Yeah, they like Florida. So that's it. Minimally invasive surgery. Patient moving his toe, tendons preserved, everything is there. Boom, boom. All that through there. Really 3 procedures. So under here, remember where this was rock hard. Can you see me poke? You know, see that now? You got some what we call purchase. So all that bone that was so tough. Look at this now. See how can you see? Notice that? I can actually pucker it. I can pucker it all around. And I need that flexible and soft tissue so this will not split open again. And we didn't go through the bottom, we went through the side. So when he's running, whatever he's doing, it's fine. And I don't want to fool with the top because it's too complicated in someone who is compromised. Okay? And I like for patients to see it too. You know, people get very, anxiety is based of two things, loneliness and fear. That's the source of real human anxiety. And when you do something to a patient and they don't understand what happened, that's a lonely, fearful position. It creates a lot of anxiety. And sometimes messes up the whole procedure because they got to be psychologically convinced we're going in the right direction. If the patient ain't convinced, I don't think it works. Yeah, right. They got to feel it, That's a Bahamian thing. If they ain't feeling it, boy, you better call on the Lord. Yes, exactly. You don't know, and then they start imagining all kinds of things. Everything in the world going wrong then. One more. Bam. Take that one off, maybe. Bam. This is our patented dressing. It's Felicia who perfected this, not me. Looks beautiful. When it comes out nice. Make you look like you know what you're doing, It helps. Because the opposite is also true. Good. So let's do this. Come on now. Gotta go right here. Raise your leg up again. Nice having the patient awake. I remember when I first started, boys have 400-pound legs. And the patient asleep. And you don't finish that hard surgery. Now, you're trying to put on the dress and you got to lift them legs and all like a muddle. And I don't even think they had Voltaren then. Those are good. Let's do something else. So it's nice having people awake. They can assist in this final process. They get to see what has happened. Good. Hammer out of dodge. Cut. Thank you for letting us do your work, sir. Do you have any questions for us at all? Anything? So no tape. Once again, I like to close that on the top. So if you get swelling in the night, you call them, say, what happened? You put swelling, waiting, boom. Put your finger here, open that, it opens. No tape. No nothing. Nice and clean. Do not go for a run. You're not going to have any problems. The nurse is going to give you a sheet, an instruction sheet. You can even see now with his dressing, this side here that big bump was on, that should be flat, even evident from the dressing. Okay, that's supposed to be flat. This is supposed to be, I should be able to put my finger in there. It's an indentation now, where that when you touch it, it was so hard. And I'm out of there. Thank you. Do well, man. We'll see you on Monday. Any problems, give us a call. And I hope we'll see you maybe in Marathon, Bahamas in January. Yeah. Come on. I think he's going to do super fine. Oh, come down a little bit.
My name is Italia Johnson. I am Dr. Johnson's sister. He was always very fun-loving, outgoing, intellectual. I never saw him study, and I always wondered, I said, Danny, you intend to go to med school? Well, I mean, what school is that? It's true. He's not perfect, but my brother is true. And he is loyal. And he's gifted. He never stops giving, and he never limits people. He doesn't see a big world. He sees a small world. But my brother is true, and he's gifted. He's a good person, and he will care for his patients. They don't have to be concerned if they have the money. I mean, you have to pay bills, but that doesn't arise. Do you think the lady that came here from St. John's Church, that they were going to take off 2 of her legs? She was the only person working in her household. Do you think she had money? And she's walking.